Well, good morning, everyone. I am so glad that you are joining us for another episode of Coffee with Cade, where we're going to have a great conversation, not a presentation. This morning, our guest is Dr. Mindy Christianson, who is head of the Reproductive Endocrinology Department at the Johns Hopkins Medical Institution. Dr. Christianson, thanks for joining us.
Thank you for having me. I'm very excited.
Awesome. So today we're going to talk about a topic that is of interest to so many people, fertility preservation. Now, you may think of fertility preservation as something that is only for people who have a disease that would impact their ability to get pregnant, like someone who, for instance, may have cancer and who was going to have cancer treatment, and that would cause their reproductive organs to stop working. But it's also an option for people who may want to preserve their ability to have children genetically related to them for other reasons. And Dr. Christianson's going to talk a little bit about why both may choose to preserve their fertility. We'll talk about costs, and we'll also talk about the pros and cons of moving forward with this. All right, so let's get started. Dr. Christianson, tell me a little bit about the types of patients that you have encountered that needed support to preserve their fertility.
Yeah, so there's a wide range of different patients who can benefit from fertility preservation. Those may include patients that have a new cancer diagnosis, which can be very devastating and very sudden. So those patients are interested in fertility preservation before they start their treatment that can be detrimental to their egg supply. And I see mostly females for these types of consultations. So women facing chemotherapy or radiation, even young girls facing chemotherapy or radiation can benefit from fertility preservation. So that's one group. Another growing group of patients we're seeing are women who are interested in elective oocyte cryopreservation. So these are women who have delayed childbearing or made the decision to delay childbearing, but understand the benefits of freezing their eggs. And the benefit is that your egg supply goes down over time and your egg quality goes over time. And so by freezing your eggs when you're younger, you're kind of helping to preserve that fertility. So even when you're 40, your chance of getting pregnant is the same as a 30-year-old if you freeze your eggs when you're younger.
That's great. So can you tell me a little bit about what that process entails, and start from the very beginning, because there may be a lot of people who didn't even know that it was possible to freeze eggs when you're, let's say, 30 and use them when you're, let's say, 45 to have a child. So can you tell us a little bit about that process?
So the way the process usually starts is that the patient or the woman will see us for a consultation. She may have already spoken to a regular gynecologist about it and got some initial information, but we start with a consultation to talk about the process. And one of the most important things to do at that first visit is to really assess her egg supply. Okay. By assessing her egg supply, and females are born with a set number of eggs that goes down over time, but by assessing her current egg supply, we can learn if it's advantageous to freeze eggs now or if we have a little bit of time to wait. The younger, the better.
Dr. Christianson, I don't want to cut you off, but can you say that again for the people in the back who didn't hear that? The number of eggs goes down over time. Can you say that one more time?
So the number of eggs that a female has goes down over time. Females are born with a set number of eggs and it goes down over time, but it's not just the number of eggs, it's also the quality. Yeah. So even if you're 40 and you have a lot of eggs, unfortunately, those eggs aren't going to be of good quality because you've had them for so long and things happen. So it's better to freeze your eggs. The younger, the better.
So you say the younger, the better. What do you mean? Are we talking 15 years old? Are we talking 25? I mean, when is the ideal age to freeze for non-medical reasons?
So ideally before the age of 35.
Okay.
After the age of 35, the number of abnormal eggs starts to increase. The percentage of abnormal eggs starts to increase each year exponentially. So it's really important if you can before the age of 35. That's not possible for some patients, and they may wait till they're 37 just due to life circumstances, and that's fine. If you're a little bit older, we would just want to freeze more eggs.
Okay. Now, I'm sorry, I think I cut you off when you were kind of midstream talking before. Yeah. You talked about patients coming in, you talked about the age and the fact that women are born with a set number of eggs and that goes down over time. What's the next step in that process?
So the next step is usually at that visit where we're evaluating the patient's egg supply. We can do that by checking a blood test called the AMH level. That's the most popular way we do it. We check an AMH level or anti-Müllerian hormone level. We also do an ultrasound and look at the ovaries. And by doing that, we can do what's called an antral follicle count to learn about the egg supply. So those two things can give us a lot of information.
Is AMH usually covered by insurance?
Generally, the AMH level will be covered by insurance because it's just a fertility testing lab. So that I've never had an issue where that wasn't covered.
Okay, so for anyone who's watching, who's thinking, this might be something I want to look into, you can actually go to your OBGYN and have some of these basic tests done before you move over to the fertility doctor, just so you have some basic information going into that. Is that correct?
That's correct.
Awesome. Okay, so they've got these labs. What's the next step?
So the next step is looking at the financial aspects. I think that's once a patient decides that they want to freeze their eggs, the financial aspects are very important. Depending on the patient's situation, she may have another gynecologic diagnosis. We can submit for insurance to see if all or part of it would be covered. In general, most of the time for elective egg freezing, it's not covered, but more and more we're finding that it is covered depending on the patient's employer. So it's important to at least check and see if it's covered.
So can you give some examples that you have experienced in practice where it was covered?
So we've had patients with a history of endometriosis or uterine fibroids or even polycystic ovary syndrome where it's been covered, or maybe the medication's been covered because they have PCOS. So it's definitely worth pursuing as far as looking to see if your insurance covers it.
That's awesome. Okay, so we've gotten our basic hormone testing. We've looked to see if it was covered, and hopefully it is. And even if it's not, how much is this usually out of pocket?
So in general, it's going to depend on how much medication the patient would need, but generally between $10,000 and $15,000 would be if you had to pay out of pocket for a cycle.
Okay.
To do an insect, and our goal is always just to be able to do one cycle. That would be optimal, but it really will depend on the patient's egg supply. That will be most predictive of how many eggs we retrieve and are able to freeze.
So I know you're at Johns Hopkins, and you may not know for all clinics, but how much are there financing programs available through Hopkins, or would someone have to just be able to come up with all the money at one time?
So if someone is just doing elective egg freezing, they would need to put down a deposit. We don't have financing, but other centers definitely do.
Okay. So they've got the money. Now what happens?
So then we get the patient set up to start the cycle, the controlled ovarian hyperstimulation. And so before we do that, we have teaching, we have online modules that our patients do, but other centers might have other ways that they teach their patients. Our nurses will teach the patients how to do the injections. So in order to freeze eggs, the patient will need to take injections in their abdominal area. They're just little subcutaneous injections with tiny little needles. They don't hurt, but the patient will do the injections for about 8 to 10 days.
Okay.
And what those injections do is they cause the ovary to make multiple eggs to develop, and the eggs grow in something called follicles. And so during that process, the patient will come in about 3 to 5 times for monitoring to see how the ovaries are responding. And by monitoring, that would involve an ultrasound in labs to see how many eggs the ovaries are making, basically.
Okay. And the ultrasound is transvaginal.
Yes, transvaginal ultrasound.
Okay, so they're looking at your belly to see how many eggs you're producing. This is a process very similar to the process that people would go through who were planning to do IVF, correct?
Correct. Yes, it's very similar to IVF, the whole process. And then once the follicles where the eggs grow are the appropriate size that we assess that the ovaries are ready, then we'll say, okay, now we're ready to schedule the egg retrieval.
Okay.
So the egg retrieval is a 15-minute procedure. The patient's asleep with just IV sedation, so she doesn't feel anything or remember anything. It's outpatient. At our center, we do it at our outpatient surgery center, and most fertility centers will have an outpatient surgery center where they have it performed. The patient goes home about an hour after the procedure, about 45 minutes to an hour after the procedure, And what we do during the procedure is, like I said, the patient is asleep under anesthesia, IV sedation. We do a transvaginal ultrasound. A little needle comes out the end of the ultrasound probe, and we're able to aspirate the fluid from each follicle where the eggs grow. We hand the tubes off to our lab that are connected to the operating room, and then we're counting the eggs as we're doing it. So that day we tell the patient how many eggs we get, and then we freeze them that day.
So what are and when you say freeze, you don't mean like stick it in the freezer. It's a little bit of a different process. Can you talk a little bit about that?
Yeah, absolutely.
Why use that instead of traditional freezing?
Yeah, so there is a very special process we use to freeze eggs called vitrification. Vitrification is a type of flash freezing of the eggs. We have to use vitrification because the eggs have so much fluid that the ice crystals can form and damage the eggs. But with vitrification, it's very efficient, and we have had a lot of success in thawing the eggs and creating embryos in the future. So vitrification works very well for freezing eggs.
Okay.
So we would freeze the eggs with vitrification the day of the retrieval, and the next day we call the patient and tell them how many eggs were frozen.
Okay, great. And so after that takes place, how much does it cost, excuse me, per year to keep those eggs frozen? And then a follow-up question, I know in the past, egg freezing was considered controversial, and the recommendation, although it's not anymore, but the recommendation was to freeze embryos. So can you talk a little bit about the success rates using the eggs versus embryos?
Yeah, absolutely. So egg freezing was considered experimental until around 2012. And that's when labs got very good at vitrification. So in 2012, it was announced that egg freezing is no longer considered experimental. And there's been multiple studies published, mostly on frozen donor eggs, showing that there's very high pregnancy rates when you have a young egg that's thawed and fertilized and embryos are created. So it's not as efficient as creating embryos. So if you had like 5 embryos frozen versus 5 eggs, there's going to be higher chance of pregnancy from those 5 embryos and those 5 eggs. Okay. But it's still very, very efficient and very successful.
And how much does it cost per year to freeze?
So at our center, the annual storage fee is $500 per year, but it's really going to vary from center to center. Some centers may be as high as $1,000 a year, but in general, I would say that probably $500 is about average. That's just the storage, and that's for all the eggs. It's not per egg. So if you had 20 eggs versus 5 eggs, it's going to be the same price. There are some off-site storage facilities where some people may send their eggs, or special banks that store just eggs and sperm and embryos. That's all they do, and they're going to be a little less expensive. So there's always that option as well.
So can you talk a little bit about the downsides of this? So, the going through the whole process, spending the money up front, spending the money annually. What are some of the reasons people may choose to not move forward?
I think it really depends on the patient's individual situation.
Okay.
So for instance, somebody may decide to freeze their eggs when they're 33, and then when they're 35, they find the right person and they get married. Their chance of getting pregnant at the age of 35 is still pretty good on their own. And so they have these frozen eggs they may not need to use. So it's kind of an insurance policy. They don't necessarily need to use it. There was a very interesting study that was published, though, that showed that it's more cost effective if you freeze your eggs when you're 35 versus waiting to do IVF when you're 40. And so there really is, a benefit. It's just that, we don't have a crystal ball, and our patients don't have crystal balls either. So we don't know if they really need to use those eggs or not. But I think it really gives patients peace of mind for planning to have those eggs frozen.
Yeah, I'm just thinking about the presentation we just participated in, it ran rounds at Hopkins, where one of the persons who went through it said it gave her the freedom to date without pressure, and the freedom to just kind of continue carrying out her professional goals and also her personal goals without thinking, I've got this long before I need to get pregnant and have a baby. So I love the way that you described it as an insurance policy of sort.